doctors. So I have come with another presentation for the Mrcp basis consultation station, and today I'm going to talk a bit about the COPD. Remember, this is a consultation station, and as you all are aware that consultation station is almost similar like long case station which we had at our undergraduate levels. So let's talk a bit about COPD. So normally in the consultation station, what will happen that you will be given some information before you enter the room, and then based on this information, you can maybe sketch a few notes about the what diagnosis you are thinking, what could be the differential diagnosis, how you'll structure your consultation. So that is just like you have to do some your brainstorming and come up with a plan. So in this case, this is the patient profiles. This is Mr. Smith, a 60-year-old male, and presents with a history of increasing shortness of breath and cough for the past several weeks. He's a retired teacher and a former smoker. Now, they have given you some hint here already that this patient is a smoker and he has been having this shortness of breath and cough for the last several weeks. So, immediately you'll be thinking about the COPD, asthma, and so it is a respiratory related case. Okay. So, once you have given that, then you'll be going to enter the room. And first of all, you're going to greet the patient. You introduce yourself that I'm one of the doctor who is working in the hospital. So is it okay if I ask you, if I take your history, ask you some relevant questions, and we'll do the examination later. So this is a kind of taking the consent from the patient and your introduction. So warm introduction and a clear explanation of your role, and then you'll start with the history. Now remember that you already have some idea that this patient has a respiratory problem. So you're going to conduct an in-depth exploration of respiratory symptoms. When did these symptoms begin? How have they evolved over time? Any triggers or exacerbations recently? So take a detailed histories. We call it in our undergraduate level like history of presenting complaint. Next step, investigate the associated symptoms. So does she experiencing any chest pain, any fever or wheezing during these episodes? Very, very important, because if there's a wheeze there and there's obviously not, and if there's a family history of bronchial asthma, previous history of bronchial asthma, maybe thinking about the bronchial asthma. Then we want to talk about our past medical history. So we're going to inquire about any respiratory conditions or cardiovascular issues that might be relevant. Very, very important, this patient. They already given you the hint that patient is smoker. So you must take a very detailed smoking history, when she started smoking, the number of cigarettes per day, and any attempts at quitting. Investigate her occupation, home environment, and any recent travels. So this will uncover her medication history and previous treatment for her respiratory symptoms. So these are all the points. You have to elaborate these points and take a good history and try your best that don't miss anything. Now, following the history, then what you're going to do is you're going to take the consent from the patient and start your physical examination. You'll start by assessing the vital signs like blood pressure, heart rate, respiratory rate, and oxygen saturation. This you must say in front of the examiner that I want to start by vital signs. The examiner may give you the vital signs that blood pressure is this, SpO2 is this, or the examiner may say all vital signs are normal. Okay, but this step is very important. You must say that I'll start by assessing the vital signs. Then you're going to proceed further and do the lung examination. So going to do the same pattern. We're going to do the inspection first, then we're going to do the palpation, percussion, auscultation. So first of all, inspection, observe for any signs of respiratory distress, any accessory muscle use or any chest deformities there. Then we're going to percuss on both sides, check for chest expansion, then auscultation for the lung sounds for characteristic findings like patient having any wheezing, crackles, or any reduced breath sounds. Then, very important, you're going to examine the patient hands and fingers because we want to look for any clubbing, which may indicate a chronic hypoxia. And then, obviously, we have to do the general clinical exam assessment to see any signs of cyanosis, obesity, or cachexia. I will not mention it, but obviously going to include the cardiovascular examination as well. Look for the GVP, listen to the heart, and look for parasternal heave. Listen for any S3, S4, any abnormality during the heart examination because patient had presented with the shortness of breath. So one of the differential diagnoses will be thinking about a chronic congestive cardiac failure or pulmonary edema, things like this. Okay, let's move on. Then sometimes you have to discuss the investigation plan with the patient. If the patient asks, normally once you have done it, then you have to summarize and present the patient that what do you think is the diagnosis. Depends on the scenarios. However, if you must have a structured investigation plan on your mind. So well through means obviously now this is a respiratory case and the patient has respiratory symptoms. So important investigation should be mentioned first. Like spirometry, we want to assess the lung function and establish a diagnosis of COPD. We want to do the chest X-ray because we want to evaluate the extent of lung damage and we want to rule out any other potential conditions. We like to do the blood tests, which include arterial blood gases to look for oxygen and carbon dioxide. How is the saturation and what are the levels, PCO2, CO2 and pH. And sputum, if there is any sputum, the sputum culture is very important to identify and target any underlying infection. And in this, I would like to add, we can do the full blood count as well, which will give us some idea about any infection, if the WBC count is high, or if there is any eosinophilia, then maybe thinking about conditions like bronchial asthma, maybe the eosinophils can be high. And we have to highlight the significance of smoking cessation as a crucial component of the management plan. Okay, we'll talk about it a bit later as well. Okay, let's move on. Now, this is very important. Once you have taken the history, you actually it should come before the examination. So once you have done your history, then always focus yourself on the ICE assessment, ideas, concerns, expectation. So we should initiate a dialogue about Mrs. Johnson's thoughts on the cause of her symptoms, address her concerns like potential impacts on her daily life or fear of the diagnosis, explore her expectations regarding treatments, symptoms relief, and lifestyle changes. So remember your eyes, very, very important. And once you've taken the history, please ask few questions. Keep this eyes in mind and ask few questions. Very good impact on the examiner, and it will be very helpful as we proceed further. Okay, so once you have done the examination, you must be having some differential diagnosis in your mind, just the repetition. So all these things you have to keep in your mind because it will help you in giving the presentation to the examiner after you have done your examination and history taking. So what the differential diagnosis you'll be thinking, maybe you're thinking about chronic bronchitis, emphysema, which is same thing like COPD, asthma, bronchiectasis, or heart failure. Okay, now I will just I'm going to repeat you may say that I'm repeating the things and again, but it is very important that you don't miss any point. So in any exams, like in this exam also, it must be PACES. The key is to do the repetitions again and again and again until you're very comfortable. So when you go in the exam, you're not going to miss any crucial thing, and it will be very easy for you to deal with the case and giving your presentation. So how are you going to present the case? I'd like to go into detail about this. So first of all, obviously, you'll greet the examiner. Good morning. I'd like to present the case of Mrs. Johnson. Mention about age, a 68-year-old female who presented with chronic respiratory symptoms. Now, I have divided the history taking into sections so you don't miss anything. So then immediately you will talk about a brief history. So Mrs. Johnson's symptoms include a gradual onset of shortness of breath, persistent cough, and increased sputum production over the past few years. She mentioned frequent chest infections, particularly during the winter months. Her significant smoking history spans 40 years, and she is still a current smoker. So this is the first part of your presentation. Then you will move on. You will not stop until the examiner asks you to stop. Then you say talk about the physical examination. The physical examination revealed vital signs within normal limits. On lung examination, I observed reduced breath sounds and wheezing on auscultation. Mrs. Johnson exhibited no signs of respiratory distress, but I noted her fingers showed clubbing. So, going to give all the positive findings. It's up to you. You can mention the important negatives as well in this. Like one of the important negative is there is no JVP is not raised, there is no parasternal heave, and the cardiovascular examination is normal. But anyhow, if you just give the positive findings also relative, that is also okay. Then you will move on. You will not going to stop. Now you'll talk about some investigations. So remember this first point in your presentations. First history, then the physical examination, then we'll talk about the investigation plan. So to confirm the diagnosis and assess the extent of her condition, I propose the following investigations: spirometry to assess the lung function and establish a diagnosis of COPD, a chest X-ray to evaluate the extent of lung damage and exclude other potential conditions, blood tests including arterial blood gases to gauge oxygen and carbon dioxide level, and a sputum culture to identify and target any underlying infections. All the relevant investigation of your investigation plan, just mention it. Now, in your presentation, it's a good idea to mention a bit about the eyes also. So Mrs. Johnson has expressed concern about the impact of her symptoms on her daily life, particularly her ability to perform daily activities. She also mentioned fears related to her smoking history and what her diagnosis might entail. Her expectations centered around symptoms relief and regaining her quality of life. Now, I'd like to add a further point in this, because if the patient presents with a chronic cough, they are a smoker, we have a lot of information on the media about the smoking, and they may be frightened or they may be thinking that our symptoms are resolved. It could be malignancy or any serious conditions. So it is very important, explore them further, that what they think, and then answer them appropriately. Then in your presentation, not going to stop here, and then we're going to talk about a differential diagnosis. So considering the patient history and presentation, the leading diagnosis is COPD. Okay. However, it's important to consider other possibilities, including chronic bronchitis, emphysema, asthma, bronchiectasis, and heart failure. Actually, chronic bronchitis and emphysema are part of the COPD. So we're going to mention about asthma, bronchiectasis, and heart failure. Okay. So if the examiner stops you anywhere, it's okay. Maybe they want to ask you further question. If they don't stop you, then you move on and talk about the management plan. For Mrs. Johnson's, I will focus on the following: smoking cessation counseling and resources to address the primary cause of her conditions. I like to start some medications, including bronchodilators and inhaled corticosteroids, to manage her symptoms effectively. I like to refer to pulmonary rehabilitation program to improve her exercise tolerance and overall well-being, and discussion of the vaccination against respiratory infection to reduce the exacerbation risks, and regular follow-up appointment to monitor her progress and make necessary adjustments to her treatment plan. So this is your treatment plan briefly. Just be focused and talk about the relevant things. Don't talk about here and there, because we have a very short time and then the examiners get bored and they get distracted. So what is important here? We want to mention about the smoking. We want to mention about what medications we're going to give. We'll be talking about a referral, and we're going to talk about the vaccination and follow-up. Okay. So now you will coming to the end of your presentation. So in conclusion, the clinical picture strongly suggests of COPD due to her symptoms, smoking history, and physical examination findings. I discussed the management plan with Mrs. Johnson, addressing her concerns and expectation, and I'm ready to address any further questions or concerns you may have regarding. Okay, so you have to just conclude it, and this is just one example. You can do it in your way, whichever way you are comfortable. But remember these things in your presentations. Once you do the presentation, I repeat again, first of all, give details about the history, then the physical examination, the investigation plan here, the patient eyes assessment, differential diagnosis, your management plan, and conclusion. Now I have put some of the questions which are normally asked by the examiners. So like the examiner could ask you, could you explain the correlation between Mrs. Johnson's smoking history and her respiratory symptoms? This question they may because once you are giving the presentation, they may interrupt you anyway, and once you are given good 2 minutes, they already have an idea that you are giving a good presentation of the patient. So they may ask you, they may interrupt you, and they want to explore further because of shortage of time and want to ask some more questions. So here they say, could you explain the correlation between Mrs. Johnson's smoking history and her respiratory symptoms? Just an example how you should respond. So Mrs. Johnson's extensive history of smoking is a significant risk factor of her respiratory symptoms. Smoking is the most common cause of COPD, and it's a dose-dependent relationship, meaning the longer one smokes and the greater the number of cigarettes smoked, the higher the risk. So in Mrs. Johnson's case, her 40-year smoking history and chronic smoking status aligned with the development of COPD. Smoking damages the airways alveoli, leading to airflow limitation and typical symptoms of COPD, such as shortness of breath, cough, and increased sputum production. Moreover, it's important to highlight the link between smoking cessation and smoking and symptoms improvement, reinforcing the importance of quitting to slow disease progression and improve her quality of life. So I've mentioned so many things here, but if you can remember maybe just a bit detail should be okay. Okay. What other questions usually the examiner asks? Now, this is a very, very common question which they ask. How would you distinguish between COPD and asthma in this case? So, one of the example of the response. So, distinguishing between COPD and asthma is crucial as they can present with similar symptoms. You know that. So, in Mrs. Johnson's case, several factors suggest COPD over asthma. Firstly, her significant smoking history is a major risk factor for COPD, while asthma is not primarily associated with smoking. Secondly, her symptoms are chronic and have a gradual onset, typical of COPD, whereas asthma often have a variable course with exacerbation and remission. Lastly, her age is more typical of COPD, which often develops in middle age or older adults, while asthma often presents in childhood or early adulthood. However, further diagnostic tests like spirometry will be crucial in confirming the diagnosis definitively. Okay, so this is how your response should be. Again and again I'm telling you that these are all only the examples. You can respond in a different way, but idea is the same. So we focus on these points, but the wordings can be different. What other questions the examination can ask? What additional test or evaluation would you consider for long-term monitoring of Mrs. Johnson condition? So if the examiner didn't interrupt you, they already know that you know what about the investigations. So if they interrupt you during the history, and they may ask you separately also. So response for the long-term monitoring of Mrs. Johnson's condition is essential to assess the disease activity, track progression, and evaluate treatment effectiveness. I would consider the following tests and evaluations: regular pulmonary function tests, including spirometry to assess the lung function and monitor changes over time, chest X-ray or CT scan for periodic evaluation of structural lung changes and detection of complications, arterial blood gases to assess oxygen and carbon dioxide level, particularly during expiration, assessment of exercise tolerance through the 6-minute walk test to monitor the functional capacity, and regular assessment of our smoking status and ongoing smoking cessation support. So these are what you're going to do how you will proceed with the long-term monitoring of Mrs. Johnson. Okay. Another very important question which they ask is how will you address Mrs. Johnson's concerns about the impact of her symptoms on her daily life? So here's a response. Addressing Mrs. Johnson's concern is a vital aspect of her care. I would take the time to empathetically discuss the impact of her symptoms on her daily life and reassure her that we are committed to improving her quality of life. So we'll focus on a comprehensive management plan, which includes providing smoking cessation counseling and resources, offering bronchodilators and inhaled corticosteroids to manage her symptoms, recommending pulmonary rehabilitation program to enhance her exercise tolerance and overall well-being, discussing vaccination against respiratory infections to reduce the exacerbation risks, regular follow-up appointments to monitor her progress and make any necessary adjustment to her treatment plan. Okay. Sorry, I'm going a bit fast because there are many slides and I want to cover all the corners actually, because COPD is a very common station. You can get it in your respiratory station. You can get it in your consultation station as well. So sometimes the examiner may ask you about the indications for the long-term oxygen therapy in patient. So you must be aware of this. This is a very common question. So what are the indications for long-term oxygen therapy in COPD patients? If patient has severe resting hypoxemia or partial pressure of oxygen at or below 55 mmHg or SpO2 at or below 88% taken at rest while breathing room air. So if the patient has this, then you start thinking about the long-term oxygen therapy and like to evaluate the patient further. Okay. Second indication, moderate hypoxemia with complications. So you've done the arterial blood gases, the partial pressure oxygen comes back between 56 and 59. SpO2 is 89%. But if the patient has other comorbidities, like there's evidence of pulmonary hypertension, peripheral edema suggesting congestive heart failure, polycythemia, by which I mean elevated hematocrit more than 56%. So in these patients also we can consider or offer the patient long-term oxygen therapy. Third is nocturnal oxygen desaturation. So desaturation during sleep leading to increased pulmonary pressures or arrhythmias. So this is also an indication. And exercise desaturation. When oxygen desaturation during exercise is relieved by oxygen supplementation. So these are all the indications. Then remember, maybe they will ask about some contraindications. So remember these contraindications as well. Absence of hypoxemia. So patient whose partial pressure of oxygen is consistently below 60 mmHg and have no evidence of hypoxemia related complications. Non-compliance, obviously, patients who are not willing or able to comply with the prescribed regimen, including those who continue to smoke. Oxygen therapy can be hazardous in the context of smoking due to the risk of fires. But remember that according to the new guidelines, if the patient smoke, we can offer the patient long-term oxygen therapy provided it is beneficial to him with counseling, with very strict counseling, especially telling them that there is a danger of fire. Third contraindication is lack of benefit. Patients who don't demonstrate clinical or physiological improvement with supplemental oxygen during a trial period. And some coexisting conditions, now situation where oxygen might exacerbate conditions like certain types of cluster headaches. So again, obviously we have to see what are the pros and cons and whether it is beneficial or not and other things. Okay. So these are just roughly contraindications for long-term oxygen therapy in COPD patients. Remember that sometimes they will ask you about the inhaler therapy. So remember these classes, short-acting bronchodilators, and the examples are albuterol and levobuterol. So remember these names. They will not ask you about the doses, but remember the doses as well. Sometimes they will ask. So what are the classes? We have short-acting bronchodilators, then we have long-acting bronchodilators. Long-acting bronchodilators examples are salmeterol and formoterol. And then the third class is long-acting muscarinic antagonist. We know this is tiotropium, aclidinium, and so on. And inhaled corticosteroids, fluticasone and budesonide. These are the two which we use in COPD cases. And then we have the combination inhalers. And which include LABA and LAMA. They combined like tiotropium and olodaterol. So my idea for to put all these things was that sometimes these simple things also they may ask that tell me a bit about the types of inhalers. So you must be aware that you must know it thoroughly that we have short-acting bronchodilators, we have long-acting bronchodilators, long-acting muscarinic antagonists, inhaled corticosteroids, and we have combination inhalers as well. I'll briefly talk about the gold guidelines and NICE guidelines. It's very important that maybe the examiner asks you what guidelines you're following. So these two guidelines are very, very important in the COPD patients. And I briefly summarize these guidelines. Both they recommend the spirometry. So persistent airflow limitation is indicated by a post-bronchodilator, FEV1 FVC ratio less than 0.7. Okay, remember this figure, less than 0.7. I'm sure that regarding the COPD, you have a lot of information already because you passed your Mrcp part 1 and part 2 return, so must be having some idea about that one. Regarding the pharmacological treatment, the GOLD uses the ABCD assessment for treatment, emphasizing the bronchodilators. And in inhaled corticosteroids, these are for patients with exacerbations and eosinophilia. So this is what the GOLD say. What the NICE say? NICE say we start with the short-acting bronchodilators, then progressing to long-acting as COPD advances, and ICS for those with asthmatic features or eosinophilia. So almost the same things. Okay. So I have put these points. So if they ask you about the pharmacological, about these guidelines, then you should have an idea. So remember the diagnosis point, remember this figure, and regarding the pharmacological treatment, how they approach. Non-pharmacological, well, they both stress smoking cessation, pulmonary rehabilitation, and vaccination. Okay, remember this one. Exacerbations, they both advise short-acting bronchodilators, oral corticosteroids, and antibiotics based on clinical signs, and give oxygen if needed. What about the oxygen therapy? Well, GOLD, long-term oxygen for severe resting hypoxemia. NICE say oxygen assessment for severe cases. So we have already talked in detail about the indications for the long-term oxygen therapy. For monitoring, the GOLD says regular follow based on severity, and NICE recommend the annual review focusing on symptom control. And regarding the end-of-life care, both emphasize discussing the palliative care wishes with advanced COPD patients. So this was my brief presentation about the COPD. Hopefully I have covered all the points. So just my final advice to you is when you go for your Mrcp examination, just keep it simple. Try to remember the simple things. Try to remember all the points which I mentioned and repeat it again and again. At least you should practice this COPD case at least, I will say, 8 to 10 times so that you're very fluent and very confident. Okay. Thank you very much, my dear doctors, and I'll see you in my next presentation.